Anyway, I'll move on to another subject, which is more a kind of across the board with the EU regulators, like the European Medicines Agency.
Yep.
Now, Thomas Lundgren spoke recently to me last year at the TOPRA meeting. I don't know if you go to that, about the work of the health technology assessment agencies across Europe or worldwide. They don't have a harmonised methodology, and that he's getting more and more requests from these HTA bodies, I'm presuming NICE as well here, for information. And his concern was, how can we because he doesn't want to delay drugs to patients, how can we use the same subset of data that the regulators are looking at, which is benefit risk, and compared to what you're looking for, which is cost benefit?
Yep.
How can we use the same data, at early stages, to get drugs out quicker? And so, what do you comment about all that whole debate? Did you speak to EMEA? I mean, have you?
Yes.
In what way?
I think that there would be obviously benefit in harmonising, and there are sort of two components to it. The first is clinical effectiveness. Most of the licensing granted by FDA, EMA are against placebo, and not particularly in the cancer field, not much in the way of comparisons against an active comparator. Now, the way you then have to deal with it is by indirect comparison. So if you've got A versus placebo, B versus placebo, then you do A versus B. Now, how you do that is quite tricky. It's not the sort of area that the regulatory authorities have any experience in at all, and they're not even sure whether they'd want to get into it. So there's that whole component, and what constitutes the appropriate comparator will vary from country to country. So there are some difficulties in that. The second problem is if you want to do cost effectiveness. Now, cost effectiveness, the decision will always be a member state responsibility. Member states would not permit the Commission to decide cost effectiveness. Not least of which because healthcare is within the competence of member states. It's not within the competence of the Commission. There are all sorts of complications though in harmonising it. The number one complication is the perspective, the economic perspective. In Britain, we take as our economic perspective just the costs and consequences for the National Health Service and healthcare. We don't take a broader perspective, a societal perspective. Now, you could do it, it's perfectly feasible. The Swedes do it. We do it, not least of which because our statutory instruments tell us we've got to take only an NHS perspective. Not the other problem with taking a societal perspective is that if you do that, you will give advantage to people who are economically active, and thereby disadvantage the economically inactive, i.e. the elderly, which would be in breach of the equity laws that are in place. So the perspective is and it's critically important what perspective you take. So the economic analysis in terms of perspective would be complicated. And of course we have a fluctuating currency which makes it slightly awkward too. So although harmonisation would be fine in theory, it's going to be very difficult in practice for these very practical reasons.
Okay. So in terms of
but I can understand from the point of view of the pharmaceutical industry, it must be frustrating to have to do it all different things all the time. And I do understand that.